Hello and welcome to Peace of Mind, a podcast about mental health, psychiatry and research at Cardiff University. I'm Paul Gauci, the Communications Manager at the National Centre for Mental Health, and today I'm joined by Professor Jeremy Hall, who's the Director of the Neuroscience and Mental Health Research Institute, and Kat Williams, who was diagnosed as autistic last year, is an autistic parent and blogs to raise awareness about the issues. Hello and thank you both for joining us. So I don't know if you want to briefly introduce yourselves. So, Kat?
So, hi, I'm Kat. I was diagnosed as autistic last year. I'm a mum to autistic children. My eldest, Matty, I can talk about today, he's given me consent. So he got diagnosed when he was 5 or 6, and it was following his diagnosis and going through all of that everything sort of fell into place for myself as well. So I have him to thank for my diagnosis, really. And yeah, I do try and raise awareness. I'm a self-advocate. I've also advocated for other people, and I do write when I can to raise awareness of how autism affects my family and other people, using mainly the social model of disability.
Okay, great. Thank you. And Jeremy?
Yeah, hi. So I guess I'm a psychiatrist. I do research into a range of mental health related issues, and I also contribute. I have a clinic every week where we offer a diagnostic service for people with possible autistic type difficulties, particularly in adulthood.
Okay. And so just sort of briefly, what is autism? How would you describe it?
Yeah, actually, there's been some flux and change in this recently, and I think this reflects a lot of psychiatry where we're trying to describe things, and our descriptions are perhaps a little imperfect. But what we do recognise is that there's a group of people who have difficulties in 2 domains, and they used to be considered 3, but 2 have kind of been lumped together. So the first ones are in social interaction and in some of the subtleties of language. And sometimes those language difficulties can be more pronounced. And so the social interaction is possibly one of the areas that I see most of. And that can be really difficult for people, challenging if they don't really get the nuances of interacting with other people, which is obviously such a big part of our life. And then the other element is, if you like, a preference for routine and a kind of set range of activities and things to be ordered, and people can find that quite stressful in their lives if, for example, there are changes of appointments or routines or structure that are unexpected. And you can imagine that if you have difficulties in those areas, difficulties might be too strong a word, but if you have personality traits in those areas, then it can make some forms of daily life more challenging. I should say that they can also, in some instances, be quite helpful. Like, it can be very helpful to have somebody in certain occupations who is very structure aware, very ordered, and perhaps, for example, very mathematically competent, which sometimes goes along with this area. So it's not always a disadvantage, but there are some areas that can bring people difficulty. I think probably the other thing to say is that, whilst we have the one term autism, it does capture a kind of range, and you get people at the more severe range, end of the range, who've got kind of learning difficulties or other intellectual difficulties, and then some people who don't have that. But we don't tend at the moment to, the kind of newer classifications don't tend to distinguish between that in terms of the overall diagnosis.
That's something that has been a welcome change in the autistic community, because while diagnostically functioning labels are no longer given out, colloquially they are still used, but they are quite harmful because you either get presumed competence, so you get somebody who is assumed to be high functioning purely because they either didn't have a language delay or their language delay was relatively slight, so they've caught up quite quickly, and they don't have a co-occurring intellectual disability. So because they can be academically bright and they can be eloquent, it's assumed that they can then deal with everything else. But actually, you can have somebody who fits that category, whose sensory difficulties are actually very pronounced. That would incorporate myself and my son. We both use ear defenders. We both have a lot of sensory issues. My eldest has got pica, which is related to his sensory need for mouthing objects. Unfortunately, it does mean that he eats them as well. And because he is academically incredibly bright, it means that the LEA are finding it quite difficult to conflate a very academically high achiever with somebody that actually has got quite significant support needs.
Yeah.
And it means that he doesn't get the support that's needed. I'm finding it incredibly difficult to get support for my needs because, again, I'm a mum. Both my children have got disabilities. I am a single mum, and people look at that and go, well, you must be very competent then. And yeah, in a lot of ways I am. But there are other things that I hugely struggle with. Sensory issues are one of them. Most of the time, if I do food shop, I need to have somebody with me because I get incredibly overwhelmed because there's too much choice. Mm-hmm. They change things around. Professor Hall was just saying about routine. When supermarkets change the aisles around, I've literally abandoned shopping in the shopping trolley and just left because I haven't been able to cope with that. But I am also very intelligent, so it's difficult to conflate the two. Then when you go to the other end of people's perceived idea of what the spectrum is, because people think that it's this linear thing, it's really not. It's more of a circle with jags that go in and out because you can be very competent in one area and need support in others. But you get people who don't communicate verbally, so maybe they use PECS or sign, or they use an AAC, which is Augmented Alternative Communication System. And people assume that because they don't communicate verbally, that they have got an intellectual disability or that they need 24-hour care and things like that. And actually, there are some very, very intelligent, highly capable adults who are autistic who don't communicate verbally. They use social media and they use blogging to get their views out. A lot of them have written books, and it's a shame that people put this massive sort of pin in how somebody communicates as to what their functioning labels are. But it's also one of those things where if somebody is presumed low functioning, it's also slightly offensive because it almost puts less worth on that person. So just because somebody does have very high support needs, it doesn't make them less of a person, and they will have their own strengths. And I think that people need to look beyond their perceived functioning labels and look at the person. And even though we all very much agree with identity first language rather than person first language within the community, so we're autistic rather than person with autism, we are all still individuals, and it is a neurological difference. It can be disabling a lot of the time because of society rather than because of an inherent issue with being autistic. Like Professor Hall said, there are certain jobs which are absolutely amazing for autistic people if you can stick with routine and things like that. Other jobs may not be so great because it'd be changing every day, but it's just finding something that supports the person and allows them to live their best life, really.
I think you touched on something important there as well in the other kind of symptoms or features that people have, and they vary. And I think, I think it's a mistake. My own view, anyway, is that it's a mistake to think of autism as just kind of one thing. There is a kind of variety. There's a range of presentation, as we've already touched on.
Yes.
But there is, in my mind, also there's good reason to think that these particular symptoms, that social and kind of preference routine, do go together. So there is something coherent about it too. But you get other features. You've touched on one there, which is the sensory features, and I see that a lot in people that I see. Can cover a range of different sensory domains actually, but sensitivity to light and noise are particularly common and really can be quite marked. And maybe tell us a little bit about how the brain is dealing with information coming into it that they are so pronounced, if you like. That's one other area. Another area that we've done some research on here in a slightly different context, but is motor function and kind of clumsiness and things like that. And
Yes.
when I ask people about this, it's really common. And I think probably in many people's day-to-day lives, it doesn't impact on them so much as adults, but I think it impacted on people a lot as children.
Hugely so. So I was 8 before I learned how to ride a bike. And as an adult, I can't ride a bike. I am the exception to the rule that you never forget how to ride a bike. I definitely have.
Yeah.
Would be dangerous to put me on one now. My son, who has said that I can talk about him, his motor skills, his combined skill is on the 2nd percentile. Like I said, this is a very, very academically very clever little boy who is 10 and can't ride a bike. He is incredibly impacted by his motor function. His handwriting is really poor, not through lack of him trying, but because he just can't manipulate the pen in a way that everybody else can. And it is interesting that Professor Hall brings that up, because amongst the autistic community, a lot of us have either got dyspraxia diagnoses or DCD diagnoses, or would fit the criteria but won't get given the diagnosis because we're told, well, you're already autistic, so what's the point in another label? My son's actually in that category. He meets the diagnostic criteria, but he's not being given the diagnosis because he's autistic.
I think that's a real issue, isn't it? Sometimes referred to a bit pompously perhaps as diagnostic overshadowing, but the idea that you got one diagnosis so you don't get another one, kind of thing. And I think it points, my experience has been that as I say, there's often this kind of range of things that go together. They do tend to go together more often than by chance, so there is some meaningfulness in it, but that there isn't a simple separation between autistic type traits, motor traits, for example. Sometimes we see people have, I think this is particularly the case in childhood, overlaps with symptoms that might otherwise be called ADHD or attention deficit. Not always, but you definitely see that overlap. And then different overlapping symptoms or comorbidities in adulthood are often depression and anxiety in particular, but not only.
Yeah.
And so and it's perhaps a slightly unfortunate feature of the way that diagnosis is set up, and also the way that services are set up, that these things tend to be kind of considered slightly separately. But really, we're talking about, I guess, subtle changes in the way brain develops and functions between people. You can say that in some cases that might be essentially a kind of range of personal difference, individual difference, or to some people it's a more severe difference, if you like. But that doesn't manifest itself in just one area.
No.
And although the diagnostic criteria focus very much on kind of social and language and repetitive behaviours and preference for routine, it's rare that you see those things in isolation, I would say.
Yeah, and I agree with that. I do have a dual diagnosis, so I've got an ADHD diagnosis as well. My son hasn't got an ADHD diagnosis, even though he ticks a lot of the boxes, because they feel that though that presentation relates more to his sensory differences. So he is a huge proprioception and vestibular sensory seeker. So when, for people who don't know what those are, vestibular is your motion, so swinging, rocking, that sort of motion, and proprioception is knowing where your body is in relation to the space around you.
Kind of balance.
Things.
Yeah,
so when you're a proprioceptive and vestibular sensory seeker, you are the person that is flapping and jumping and rocking and literally bouncing off walls. So it does very much look like, particularly in little boys, like ADHD, but actually it's about being able to unpick that and finding out, is that actually a separate diagnosis, or is it related to what's already been found? The only danger as a sort of layperson that we see on the ground, whereas medically and from a psychiatric perspective, that makes a lot of sense, if you don't have the label, for want of a better word, it's incredibly difficult to get access to support. So, for example, going back to the difficulties with getting support for my son, because he doesn't have a dyspraxia diagnosis, it's been disregarded from our request for support, because it's almost saying, well, if he was dyspraxic, he'd have the diagnosis. And even though we can evidence with a report that he meets the criteria and it should just be needs-based, unfortunately, because there isn't enough money, there's not enough money in health, there's not enough money in education. So the actual diagnoses do make a huge difference to accessing support.
Yeah, I wholly endorse that. And I think, that there is this issue about having a label and it being, even though I very much recognise, as somebody who practices in this area, the imperfections of that label, and in fact, if one's being really honest, the imperfections of many psychiatric diagnoses. Nevertheless, they are a portal or an access way. And I think that you could say exactly the same for the diagnosis of autism itself, really. That it's, I don't believe, and I don't think I'm going to be easily changed from this opinion, that we're looking at one uniform entity here, but having that label can help a range of people and open the door to some access to services and support. I mean, if it's of interest, well, I didn't start working in this area till about 5 years ago, and I came when I moved down from Scotland to Cardiff, and I was working out what would be a kind of interesting clinical area to work in, and spoke to colleagues here. And Mike Owen, or my colleague, suggested that I might take an interest in this area. And I would say that I was a little bit sceptical at first, if I'm being honest. I thought, well, who are these people who are going to be diagnosed with this developmental condition in adulthood, who haven't been kind of picked up before? And if they haven't been, surely it'll be very minor, and there's not much we can do for them anyway. And is it really a great use of my time? I'll be honest. And but I'm always up for trying to see what could be useful. So I started actually, the first clinics I did were out in Gwent, and I was really struck quite early on by what a big group of people there are who haven't had diagnoses, who do have a significant range of difficulties that definitely impact on their lives. Often their families are worried about them too, and how they're going to be supported and things, and have these kind of core areas of difficulty, but also often and variably these overlapping problems as well. And also that increasingly how it's been possible to offer some support for that. I say increasingly because I'm pleased to say that the Welsh Government's put some more funding into this area, so we can now offer a bit more in terms of support and through the integrated autism services. So I became a convert, if you like, to the importance of this kind of work.
Yeah, it's funny you should say that, because it can be quite shocking to people when you say you've been diagnosed as an adult, because they've got the same idea. Well, surely if it was a problem, you'd have been diagnosed as a child. But I, for example, was under educational psychology in school. I was a bright, well-spoken girl from, a polite, well-spoken family who didn't get into trouble, always wanted to please, clearly had emotional regulation difficulties, which is why I was under educational psychology, clearly had executive dysfunction, clearly had social communication difficulties. But this was the 90s, and girls didn't get diagnosed as autistic in the 90s unless they had an intellectual disability and a pronounced speech delay, because what was then Asperger's was literally written in the DSM as a boy's condition. It was in there. This affects boys, very rarely girls. So nobody ever suspected that a girl could present with what was then coined Asperger's. Same with ADHD. Girls did not get ADHD diagnoses ever at that age. Okay, I might be a bit hyperbolic. You may have found a few, but there definitely weren't the number of girls being diagnosed as with boys. And some of that is to do with girls generally being better at masking difficulties, and that's not just autistic girls or girls with any other neurodevelopmental condition. That's across the board. Girls are very good at mimicking generally, and I am generalising, I know that, but so they do tend to get missed because they mirror play better than boys do. So whereas autistic boys would tend to play side by side, girls would try to get involved and copy what somebody else was doing. So to somebody watching from the outside, it looks like they're joining in and that they're fine, but actually they've got this one person. Generally it's one person, even in a group, that's their person that they copy. And if that person's removed, then you actually get to see where the difficulties lie. I don't know if that's something that you agree with, Professor Hall, but...
Yeah, no, I think that's right. Let's come back to the differences between men and women, because that is really interesting. But I want to ask you something for your opinion in the meanwhile, which is, the diagnostic label of Asperger's has kind of faded out a bit. It's not in the more recent manuals. Did you think it was a useful thing, or are you pleased that it's gone by the wayside?
I'm pleased that it's gone by the wayside. I've got a couple of reasons for that, but the main reason is going back to the presumed competence. If you've got an Asperger's diagnosis, people see you as a very, very, very clever, quirky person, and that is all they see. So when you say that you find some aspects of life quite disabling, you're almost ridiculed for it, because it's like, well, no, because you're clever and you can talk and you're eloquent, and so you can't have any difficulties. Whereas I think having an autism diagnosis, where I know that can be quite difficult for some people to accept that I've got the same diagnosis as their child who may have a significant intellectual disability, isn't communicating verbally, and has very high support needs. I think that's where support needs come into it. So having an autism diagnosis, because actually the core components of autism, regardless of any other co-occurring conditions, you all meet the same criteria, really. It's the co-occurring conditions that make a person more or less able to live in our society. So support needs are a better way, I think, of discussing what a person needs, because you can have somebody who meets the old Asperger's criteria, I'm one of them, who could still have low support needs, but you could actually have somebody who met the criteria for Asperger's who has very, very high support needs, and that can actually fluctuate as well, because before I was diagnosed, I had a huge mental breakdown. I was incredibly ill. I was self-harming. I attempted suicide. I was, for want of a better phrase, very low functioning. I was not this person that you would imagine if you saw Asperger's or high functioning written down. And I think that goes to demonstrate that labels based on intellectual and verbal capability are not a reflection of how somebody is coping in day-to-day life.
Yeah, I think that's a really good summary, and actually it's quite helpful for me to hear that, because I must admit I've seen both sides of this, and some people have found that diagnosis helpful, and I guess at times I've found it helpful because it kind of perhaps gives a clearer description. But I really take your point about how you don't want to give a false impression of the level of people's needs. So it's really interesting to hear that. Thanks. The thing about gender or sex differences is a complicated one, to be honest. And again, I guess you like to sit there. People very think that because you've got the title professor, you've got the answers to everything. I definitely don't feel I have the answers to everything. And these, there's quite a few complicated things in this. But I guess I could give a few observations there, and it would be great to have sort of your further thoughts on it, really. But I mean, there is I think we know from basic research, and it's not really that surprising. I mean, firstly, it's not surprising at all there are differences between men and women. I think we can all agree on that. And one area that there is a difference is in things like social interaction and emotion processing. And probably a big part of what social ability is what you were talking about, which is the ability to mimic or kind of understand or copy other people's social behaviour, if you like.
Yeah.
And so it could be that there's, if you like, a degree of protection, at least in terms of the way that things are seen,
Yes.
for women compared to men. So I don't think that's complete, and I still think, if people have symptoms, then they have symptoms, and they merit a diagnosis on the basis of those. But I think it can be subtly more difficult sometimes to pick these things up in. Would you agree?
I would agree, but I also fear the generalisation, and I know that particularly in a podcast where we're limited for time, you can't go into all of the different nuances. And I agree generally that there are fundamental differences, but I think a lot of those, and maybe not necessarily on a sort of neurological basis, but on a socialisation basis. So boys and girls are socialised very differently, and they are, regardless of what a parent will say, they are brought up differently. So, and then the diagnostic criteria was written with boys in mind. So, I mean, one of the AQ questions, it talks about cars and playing with the wheels of a car and mechanical things, and so a girl wouldn't necessarily fit that criteria because they may not have ever had cars bought for them. So, if asked that question, when playing with cars, did you play with just the wheels or did you drive them around, they'd go, well, no, I didn't do that. But then you need to go into, well, what typically female things can we then change this question to encompass what their experiences would be. So, for me, it was I had dolls and I played with dolls, but I didn't play with dolls in the way that everybody else did. I lined them up and gave each one a spoon of food, and then would go back to the beginning, and it would just be that on repeat. So even though to somebody doing a quick glance, it would be, oh, look, they're playing with their doll, feeding them. But it was this very copied, I'd seen somebody else doing that with a baby, and it was very much 1, 2, 3, 4, 5, 1, 2, 3, 4, 5 sort of thing. But I also think that it's important to understand that it's not girl versus boy presentation, and actually you can have some boys who present in a typically female way, and you can have some females who present in a typically male way, and there is a danger of particularly actually the boys presenting in a female way, them getting missed because they don't tick all the boxes that a typical autistic boy ticks. So then they become the child, and I quote, that's difficult to unpick. But actually, if you look that there's a couple of different ways autism presents, rather than labelling them male and female, then that might actually be a bit more helpful. But yeah, I mean, I score very highly on the AQ. I score within the male range on the AQ. I think my score was something like 47 out of 50. So, from that respect, the difference in presentation on paper isn't different for me, but in practice it is, because I was taught social niceties probably a bit more than, say, I would have been if I was a boy, and I was taught different coping strategies. And yes, I probably am better at masking and mimicking other people's behaviour than a typical man would be, but that's not to say there's probably a man out there that's much better at it than I am. So yes, it's important to understand there are differences, as long as you don't ultimately only categorise the different sexes in those areas.
Yeah, I guess, there's still a bit of an outstanding question to my mind about whether there is fundamentally sex difference in rates. It seems at the moment that there is, but I don't think we have perfect knowledge.
No.
And if there is, why would that be the case? There have been theories out there. I mean, one of the well-known ones, I'm not saying I especially subscribe to it, but it's well known, is Simon Cohen's theory about male brain development and the exposure to androgens and the like. There's controversy in that area, really. And I think we just don't truly know the answer at the moment. I've got another question for you.
Okay.
Which is, what interventions do you think are helpful? So, having had your diagnosis, there's some degree to which just having a label is of some benefit, and I think that can be a considerable benefit, actually. But did you find anything else particularly helpful, or have you seen other things to be helpful?
For me personally, I found it quite difficult to access services. So I think because I have got very good insight, and because I'm a bit of a compulsive researcher, I'm very knowledgeable on autism. One of the only things that could be offered to me was a post-diagnostic course, and at risk of sounding sort of big-headed, I already knew what they were going to teach me, so I couldn't go anyway because it conflicted with my parenting responsibilities, but I don't think I'd have found it particularly helpful. Now, for me, two of the most disabling aspects for myself are my sensory issues and my executive dysfunction. So,
do you want to just explain what you mean by executive dysfunction?
So, executive function is somebody's ability to organise their lives, basically. So it's your internal clock, so knowing roughly how long it takes to get somewhere, or knowing how long roughly you need to get ready for something. It's also your ability to prioritise tasks. It's your ability to move from one task to another. It encompasses quite a lot of sort of internal things that a lot of people, I think, take for granted. Whereas I struggle with those things. Time is one of my big issues. Didn't learn how to tell the time until I was well into high school, because it was a concept that was completely beyond me. And even now, sort of on the way in, I was joking that I'm always either really early or really late to things, because in my mind, I live in Cardiff. If anything is happening in another area of Cardiff, in my head it takes half an hour to get there. And that is regardless of whether or not it's down the road or across the other side of the city, because I just can't seem to fathom that, there are such things as traffic and possible roadworks and things like that. So it's your sort of mental planning and then execution of those mental plans. I find it very difficult to go food shopping. I've already touched on that. But it's because you've got to consider expiry dates on food. So when you're planning your meals, you've got to make sure that all of the elements for that meal all expire within the same length of time. And then you've got to think, well, do I have any of those ingredients at home? And it's being able to deal with all of that. So that's an area I find very difficult. And again, because I'm well-spoken and intelligent, people find it really baffling that I can struggle to, write a shopping list and things like that. With my sensory issues, like I've said, I do use ear defenders. I've got in-ear ones because, as much as I am incredibly proud to be autistic, I know that people look when I wear typical ear defenders, again, because if they know me, they can't conflate having quite pronounced sensory issues with my outward presentation, as it were. I'm touch sensitive. There are certain textures that I can't touch. I can't touch jelly. It makes me retch. It's awful stuff. But it's the internal sensations that I struggle with the most, I would say. So my sort of, from a layperson, quite newly identified sense is interoception, which is your internal systems telling your brain you need to have a drink, you need to have something to eat, you are cold, you're hot, you need to go to the toilet and things like that. I literally forget to drink and I literally forget to eat. And I'm using the word literally not hyperbically. So, my partner will message me asking if I've had a drink yet today, and it'll be sort of 4 o'clock in the afternoon. I'll say, no, I haven't. And it's a very, very specific thing that I have to do. So I did bring a coffee with me this morning because I had in my mind, I'm not going to be home for quite a while, so you must remember to take a drink with you. But actually, if I was at home, I probably wouldn't have had one by now, because I just don't get that feeling of being thirsty. I don't get the feeling of being hungry until I'm ravenous. There's no sort of build-up, or if there is a build-up, I can't sense what that build-up is. So again, my partner will be, oh, you're quite snappy. Have you eaten anything? And I'm like, oh, no. And he's like, you're hungry right now. And I'm like, oh, but I don't feel hungry and I won't have eaten anything all day. So again, it's quite difficult for people to think, oh, but, you've got children and you make sure they're fed and watered, how can you forget to do that for yourself? But if you don't have those signals, or your brain is misinterpreting those signals, it's very easy when you're wrapped up in other things to forget to do those things. And I'm also one of those that leaves going to the loo until the very last minute, because again, I don't notice it until it gets to that sort of almost critical point,
So I guess for you, kind of practical support from the people around you and kind of understanding how you need to adapt your own routines has probably been some of the most helpful.
Oh, definitely. Yeah. So I do have a lot of support from my partner. My friends are great as well, but my house is basically one massive visual schedule, because my eldest has got huge difficulties with his executive function and organisational skills as well. So we've got visual timetables on the walls, we've got visual schedules. So we've got a morning schedule, which is, get up, have breakfast, get dressed, brush teeth, and it's necessary for them to be up in our house, because otherwise we generally do forget to do one of those things. And even though they do seem to be fundamental aspects of getting ready to go, if they're not there, we will miss one of them out. And obviously I don't want to be that mum that sent their children to school without brushing their teeth, but if it's not written on the wall, it's not gonna happen. So I do think visual aids and things like that are hugely important, regardless of your intellectual capabilities. I mean, it's called a visual when an autistic person uses it. It's called a reminder list when a neurotypical person uses one. So I think, going back to labels, I think we just label things slightly differently. And for my son, he's had a lot more support because he's a child and he got diagnosed as a child. So he's had input from occupational therapy. He's had input from speech and language therapy, physiotherapy, and they have been incredibly helpful.
And what kind of occupational therapy input was particularly helpful for him?
He went on an intensive course. It was called the Little Ones Group, which is run in Cardiff, and that was basically for functional self-care skills and for fine motor skills. So things like doing up buttons, cutting up food, preparing a very, very simple meal of a sandwich and things like that. And even though those aren't skills that he's fully developed, they're still emerging skills. He is better than he was before he had that. It is mainly functional skills that OT have worked with him. He hasn't had as much sensory input, but he has had a sensory diet written, which is not food related. I need to point out, a lot of people, when I say sensory diet, they think, well, why would different foods help with sensory input? But it's not. It's basically activities to do at specific times during the day to help with sensory regulation. And he's found that brilliantly helpful. And I look at what he's had, and I do think, oh, if I was diagnosed as a child, I would have really benefited from some of those interventions.
So I think occupational therapy can be really helpful, along with some kind of, for some people, things like some kind of psychological inputs tailored to specific areas, be that mood difficulties, or be that things like social skills training.
Yeah.
But I do think the OT is really important, and it comes back, I guess, to the point that we discussed a bit earlier about, I mean, a lot of people want to have an occupation, and everybody really wants to get on with their lives in some ways.
Yeah.
And I think getting help and guidance about how best to do that, and that occupational therapy can really, really help there, I think. So that's something that we've, with the integrated autism service, had more access to, is kind of psychology and occupational therapy, and some other things like speech and language or dietary input as well. And I think that's really good. I guess it's probably worth mentioning as well at this point, another Cardiff-led project that we're very pleased about, which is the Engage to Change project, I believe it's called, which is run by my colleague Stephen Bear, which is about getting people into suitable employment. There's obviously it varies a lot with the individual person, but that's another important area of overlap, I think, between adults with autistic type traits and the ability of that project to help put them into suitable work placements and get more experience. I think it's been a really great initiative, supported by the lottery, I think, wasn't it?
Yes, lottery funded, and we'll put information about the Engage to Change program on the episode page for this podcast. But basically, Kat, if you've not heard of it,
I haven't heard of it, and I think things like that are really important because such a low percentage of autistic adults are in employment, paid employment, and I'm going to say paid employment because a lot of us in voluntary work. I used to do voluntary work. I've stepped away from that for the time being. But people don't seem to want to pay autistic people for their expertise. So people will have events where they'll get speakers and they'll pay the medics and they'll pay the people who work in mental health. And then they'll say, we've also got an autistic speaker, and they won't pay the autistic speaker because they're giving them exposure, I quote. And it's almost like when you have artists and people say, oh, will you do a painting of me? And they say, yes, it costs £100. And they say, oh, no, I'll put it on my social media for exposure. And I think that one of the issues is going to the social model of disability. A lot of workplaces are not set up for autistic people, and it's incredibly difficult to stay in that environment. Before I left paid employment to be a carer for my boys, who do have more support needs than I do, I used to work in a law firm, and I was good at my job. I got my job done well. But if I was asked to drop something, if something else came up that was more important, I find it really, really difficult to stop what I was doing to move on to the other task. It would be very distressing. And I also found that I would do what I thought was a good job, and the outcome was a good outcome, but apparently I didn't talk to the people on the phone in the way that I should have, and I found that quite confusing because I said, well, did I say anything wrong? Well, no. Did I upset them? And it's like, well, no. And it's like, well, I don't understand what you mean then. And I think one of the ways that this can be helped is actually by businesses employing autistic people to come in and almost do a sort of walkthrough. So walkthrough, pointing out all of the things that could cause sensory issues. So if, it's an office building that's full of flickering fluorescent lights, pointing that out and saying, well, did you know that we can actually hear those fluorescent lights? You might not be able to, but that's really distracting. But also to basically explain how an autistic mind works and how, whereas you could maybe tell a neurotypical person to drop everything that they're doing and do this task right now, maybe just, even if it's a 10-minute warning, and say, look, something else has come up, you've got 10 minutes to finish what you're doing or get it to a point where you can leave it, but then I need you to move on to the next task. Because again, even though people who autistic people can be very intelligent and have very high powered jobs, you've got autistic doctors, you've got autistic solicitors, you've got autistic teachers, which I think there should be far more autistic teachers, to be honest. I think it would do the world a lot of good. they still have the difficulties that come with living in a world that's set up for neurotypical people. So yeah, that was an interesting noise.
I think there's some volume switch left on my computer, for which I to provide a unexpected sensory interruption for you there, just while we're talking about sensory interruption. Sorry about that.
No, but I think that the programme sounds absolutely brilliant, and if it helps autistic people get into paid work, then that's amazing. But I also feel that projects like that should have input from autistic people to actually, I think it's very easy to learn from books and from doing a job, and obviously people are very highly qualified, and I'm not disputing that at all, but actually unless you are autistic, you don't know what all the nuances are, and all of the, you could say these are the sensory things that would possibly affect people, but actually if you get an autistic person in, they're going to be the one that spots the thing out of the corner of their eye that's going to be a major distraction. So I think that that could be one way of getting autistic people into work, is employing them in the jobs that are helping autistic people, you know, peer support, be the ones that deliver the training, be the ones that talk at conferences, and actually, you know, pay them.
I think there's definitely an opportunity for you to set up a business there, Kat, you know, in terms of guiding companies. I mean, I had a colleague, a clinical trainee, who did some work looking at responses from people who'd mainly been seen in our service or other similar services nearby. So the colleague's a young doctor called Jack Underwood. And it's maybe just worth mentioning a bit of what he found, because it echoes some of what you're saying really about people's experiences. So and he's written this up. It's been published in the British Journal of Psychiatry this year. So he found that there were low rates of employment, despite, you know, my experience being that many of the people that I see clearly could be in employment if the right support and employment were offered. And I think that's really a big issue and a big challenge. It's why I highlight these things like occupational therapy support and you know, the Engage to Change project and the like, because I think it's really important, because all of us, well, we all have our, I mean, you're obviously working really hard as a carer at the moment, and that's a very important occupation in itself, but we all have a desire to be doing something useful, and I think it's really important that people get that opportunity. The other thing we highlighted, and I think this is important, you know, I guess for me as a psychiatrist as well, is that you do see these high rates of other problems in people who, you know, get a diagnosis of autism as an adult. And top of the list, and over kind of well over 50 into the 60% of people that we've seen would report having had depression or significant anxiety symptoms. And that's definitely my experience of seeing people. And there are a few other studies out there that support that. And of course, your own experience suggests you had difficult periods.
I've had clinical depression. I'm not in a depression at the moment, which is great, but I have got very, very high anxiety. It is quite disabling, and it's quite difficult, again, to get support for things like that when you're autistic, and it's because you have symptoms that would feed into, or a mental health condition that would feed into primary mental health, but you're actually too complex a person for primary mental health to deal with. So then you're passed to community mental health, who actually don't have the resources to help with something like anxiety, because they've got so many people on their books with very, very significant mental health conditions. The other thing is as well that a lot of people, particularly women, get misdiagnosed with personality disorders. So I had a working diagnosis a few years ago of borderline personality disorder, but then it was felt that I didn't actually meet the diagnostic criteria, because there are certain elements that I don't meet, such as the emotional lability being relating to triggers rather than it actually just being an inherent part of me, and there are other things I won't go into right now, but I'm also in the process of being diagnosed with PTSD, which I know a lot of autistic adults have diagnoses of PTSD. Again, I think because when something traumatic has happened in the past, we process things very differently. And if we haven't had specific support in how to deal with trauma relating to being autistic, and of course we won't have been if we haven't been diagnosed before then those symptoms sort of do tend to linger and feed into that. So I would say that actually, other than being a carer, and I love my children and will of course prioritise them before anything else, I would love to be in paid employment. Like, I genuinely really wish that I was in paid employment. Unfortunately, it's hard to find a job that fits around school hours, because realistically that's the only time I can work. But actually my biggest barrier to employment, and the reasons that I got signed off when I was in paid employment, were all relating to mental health rather than to inherently, well, I wasn't diagnosed then, but what you would see as inherently autistic issues, they were the co-occurring mental health issues.
Yeah, no, I think that's important. And I guess for me in my role, that's something that I hope I can bring a little bit to the assessment and support of people. Obviously it provides some opportunities for other specific interventions, because, be it psychological therapy or be it medication or whatever, there are ways that we can help. Another area that we do see some of it's rarer, quite a lot rarer, but we do see a little bit of overlap with things like paranoia and psychotic symptoms in some people, and with OCD, which I think is not surprising really, given some
that's not surprising.
Okay, the other thing that Jack looked at, and I guess is another area it's interesting to think about, was could we understand anything about the causes of presentation and the risk factors, if you like, in people presenting, particularly as adults. So there's been much more research on people presenting as children for a whole host of reasons, really. So the work we did, I guess, adds something in terms of looking at adults. And because of our close linkage with the National Centre for Mental Health, and a lot of people who come through the clinic have also contributed to the National Centre for Mental Health cohort, we were able to have a look at some things. And one thing that Jack did look at was genetics. And I guess the picture, at least within the number of people that we were able to look at, was, to my mind, quite interesting. He didn't find, or we didn't find, evidence for the kind of more severe genetic changes that you sometimes see in children presenting with autism. But what we did see, even though the sample wasn't that huge, we were able to detect a clear signal of what we call polygenic risk. Those are variables, genetic variables that we all have, thousands, nay, millions of them, but that perhaps some of them subtly increase particular traits. And some of them have been shown in other samples to be associated with autism, and we found that they were more prevalent in our adults with autism as well. And so it suggests that it's that kind of general genetic makeup that's maybe contributing a bit. And I think it would be really interesting, and one of the things that Jack wants to go on and look at a bit more is whether that also contributes to some of the co-occurring symptoms as well.
Yeah, I mean, if you just look at the number of adults that are being diagnosed and they've got autistic children, and obviously I'm not a medic, and even if I was a diagnostician, but if I look at my family, there are definitely people in my family tree that I can quite safely say would probably meet the criteria for a diagnosis. And when speaking to other members of the autistic community, they're saying the same thing, that it's autistic parents have autistic children, they can see the signs in other members of their family. So I know that the autistic community very much subscribes to it's genetic. The only thing that we're concerned about with the research is what that's going to be used for, because if it's used to aid diagnosis and to help provide services, then that's brilliant. The danger is that you get into the antenatal testing, and then you get what's been happening with Down syndrome, is that parents are then choosing to terminate pregnancies. And obviously you know, it's a woman's right to choose. I firmly believe that, but I also feel that people can be quite scared of autism. I mean, look at the damage, you know, Wakefield did with his, you know, non-science, and people are scared of it. So there is that worry that we have as a community that in the wrong hands, the research is going to have sort of negative outcome for our community, even though it's helping us at least in the short term, because we spend our days battling people on the internet that are telling us that we're vaccine damaged or that we're full of mercury and things, and there's only so many times you can tell somebody that they're talking nonsense, even if you show them all of the papers discrediting that. You know, if there was a firm piece of research that we could say, hey, look, it's actually genetic, can you go away now? That would be helpful, but, you know, as long as our sort of fears are dispelled that it's not going to start becoming one of the amniocentesis tests, you know.
So there's quite a lot in there, and I'll try and just add a few comments. One is just to say one other thing Jack found, which I think you'll find interesting, is that as well as the kind of depression and anxiety and things like that, another thing that we found very high rates of were of particular types of neurological presentation, especially migraine headaches.
That's
and yeah, it is interesting, isn't it? Because again, it points to this, you know, very real brain-based mechanism, which that's something we're going to look into a lot more. And the rates were really high, actually. So that was an intriguing and, I must admit, slightly unexpected finding. So, So in terms of the genetics, I mean, the genetics that we found in the adults, and certainly in the people that we looked at, you know, because it's many small genetic changes rather than one big genetic change, that's really not so suitable in any case for prenatal testing. So we can be a bit reassured in that area. On the whole, even the more significant changes, the biggest class of which, these are more often seen in kind of children presenting with developmental difficulties, called copy number variants, which are a gain or a loss of a kind of appreciable chunk of genetic material. We all have a few of them, actually, but some of them are more associated with different presentations. Even there, very few of them are absolute. You know, I guess in Down syndrome, I'm not making a comment about whether one should or shouldn't do different types of prenatal testing, but just in Down syndrome, if you have 3 chromosome 21s, then you are going to have Down syndrome.
Yeah.
But with these variants, you know, they perhaps alter your risk a bit, some more than others, but they're not deterministic. They don't mean that you're absolutely definitely going to get a given condition. So that, I think, makes this whole area very complicated, actually, but certainly leaves me also being a bit uncomfortable about, you know, kind of prenatal diagnosis and testing, because, you know, it may well be that you know, people with those particular variants are going to be relatively fine, and certainly not necessarily severely disabled. The other thing to say is that, you know, whilst genetics, I think, is certainly important in the context of autistic traits, and is probably why we see these things run in families to some degree, that you mentioned yourself, that we don't think that it's only genetics that can contribute to risk, and there are other early life factors that we know can be important. There is a small but appreciable increased risk of developing autistic-like traits if a baby is born very prematurely or very low birth weight, for example. We don't fully understand the reasons why, and there are probably other early life factors that can affect risk as well. So, you know, various obstetric complications, for example. So it's not a kind of, I think on the whole, we're not, in the majority of cases anyway, looking at kind of genetic determinism. Yes. We're looking at a genetic contribution, perhaps.
Okay. Yeah, that is reassuring. And
yeah, but it's a complicated message to get clearly out, isn't it?
It is, definitely. Yeah. Especially sort of on a podcast when you're talking to somebody who isn't a scientist. So, but yeah, it is reassuring to hear that, and I'm sure that other members of the autistic community would be reassured by that message as well, because you know, we are very proud of who we are, and I think that as a community we are probably one of the proudest sort of community of people with what's classed as a disability. And it is quite upsetting that there are people out there that would like to, for want of a better phrase, get rid of us. So it's nice to know that in this instance, science is it is on our side, and even if those parents were of that frame of mind, they wouldn't be able to use it anyway. So that's good to know.
I think that's true. I think it's really good also that you mentioned the Wakefield and the vaccination stuff, because I don't think we can say too often what you said, which is that, there has been no proven link between vaccination and autism. I can see why some people might have been seduced by this as a possible explanation, because of course people are vaccinated at about the time that also autistic symptoms can become more apparent. But there is no link in terms of the rates of vaccination and the rates of autism. So it's really good to reassure people of that, because there are definite risks of not being vaccinated.
Well, yes, there are, definitely.
Yeah, I think that's probably a good place for us to end now. So thank you both for coming in and contributing to this podcast. I think it's been a really, really interesting discussion. Just to let people know, if you're listening and you want to find more information about any of the topics we've discussed, if you go to ncmh.info/podcast, you'll find information on this episode there. And if you have enjoyed listening, please do leave us a review. And that's our cue to go. So thank you very much. Bye.